All right. And I am so excited about our presenter today, Dr. Wendy Mohlman. She is the program manager and RN guide navigator for the guide program at the University of Utah's Aging Brain Care and Madsen Geriatrics Clinic. She holds a doctorate in nursing education, a master's in gerontology, and a bachelor's in nursing. Her background spans Alzheimer's and dementia care, hospice and palliative care, mental health, and regulatory compliance. Prior to her current role, she served as the Hospital Elder Life Program Nurse Specialist at the University of Utah Hospital and has held leadership and clinical roles in assisted living, memory care, and hospice. Dr. Mohlman also teaches undergraduate nursing students and is a Daisy Award-winning faculty member. And she volunteers with the Alzheimer's Association and ADRD workforces. With that, I'm so excited to turn the time over to Dr. Mohlman.
Thank you, Dr. Kelly. Hi, everybody. On behalf of the Aging Brain Care Program at the University of Utah, I'm really happy to collaborate with just the advocates and experts in this field, and then the ambassadors. So we're just really delighted to be here. So as a disclaimer, I just want you to realize I'm not a medical provider. I'm not a doctor. And so this is for informational purposes, it's not about medical advice, but just to make sure that you receive the education. And anyway, if you have any questions, make sure you consult your provider. So let's talk about our mission today. When a family gets a dementia diagnosis, right, it's not just about the patient, but also when the family receives the diagnosis, they worry about treatment and prognosis, money. How do they not get lost in the shuffle? And that's what we're going to talk about today. We're going to unpack this whole journey from getting an accurate diagnosis to current treatments, potential future treatments, and we'll end on discussing the support system that focuses not only on the patient with dementia, but also their caregivers and their families. So by the end of this presentation, I hope that you'll be able to identify some key methods in the assessments that medical providers use, summarize the current treatment options from medications to, we'll talk about the infusion therapy, and then support services. And then I'm excited to tell you about the CMS guide program. So by the time I finish this sentence and all of this, there's another person somewhere in the world that has developed dementia. Every 3 seconds, a life is changed, and their family, their lives are changed, and they are navigating the unknown. As the numbers rise, so does our responsibility, and but it's also our capacity to make a difference. So rising numbers can also mean rising support. So there are normal age-related changes in cognition. And, sadly, some of us, we already feel this as we age, but the cognitive processes start to slow. And the ability to concentrate on multiple tasks, that goes down, which is very frustrating for people. Spontaneous word finding. I think we all have struggled with words. And when you work in this field, you're just like, oh no, is this a sign of cognitive impairment of some kind? And that's pretty normal with aging. Normal age-related changes can develop into memory impairment, and that's a symptom, an aspect of memory that just isn't working like it used to. So memory impairment, it can be normal, it can be temporary, and it just doesn't affect daily function. And I remember a doctor, I just thought this was the best analogy, but the doctor was explaining to a patient that, with memory impairment, it's like a bookshelf in a library, and there are a few volumes that are occasionally misplaced, but they're not missing, like as in dementia. So when do these symptoms stop being normal? When are they no longer considered age-related changes? So let's briefly review what happens in the brain with Alzheimer's disease or other related dementias. It can definitely be challenging, for doctors because, some of these symptoms are so subtle at first. of course, when it's an early diagnosis. Family members, they're the ones who commonly recognize, especially behavioral changes and mood changes. So in the brain, and this is what's happening, we think about where things are from the different lobes and what the different, parts of the brain control. The brain with this disease becomes inflamed. And so it occurs in response to the atrophy of the brain, the tissue, in the hippocampus and the cerebral cortex. So that can cause the brain inflammation, all the atrophy. We think about the reduced gray matter, and again, that can result as the brain is being severely reduced. Changes in personality, that's really where we see a lot of the changes. And then we think about the enlargement of the ventricles in the brain. And again, from the increased tissue atrophy that surrounds the ventricles, and that leads to brain damage. So to put all this into perspective, I want to talk about John, my father-in-law, and I'll use him throughout this. So John also had those age-related changes. However, the changes that he experienced, it impacted his ability to be independent. And then he became unsafe. And so, I remember we would see odd scratches and dings on his truck. He didn't know where they came from. He got lost in walks in familiar areas. He forgot to pay bills. And as you can see, a very accomplished, distinguished man, very successful. He kept buying the same book over and over. He forgot that he had it at home. And I think one of the hardest ones was when they called my husband, Costco. And because my father-in-law, he didn't know how to get home from where he was. So of course, this wasn't a memory lapse. It was a failure in executive functioning, that part of the brain. Again, diagnosing it can be hard, especially because John was adamant that it was more about the family being paranoid. Of course, he didn't want to admit it. He didn't see it like we did. So the first steps in the assessment are about subtraction. Really, that's what it boils down to. The medical providers have to rule out the possible causes first. So for instance, the memory test, the dreaded memory test I hear from our patients, this is where the MOCA, for example, it's looking at attention, memory, language, problem solving, and of course the clock drawing. Another important scale is the depression scale. We'll go a little bit more into that. Important medical history. The providers need to know about head trauma, a cardiac history. What about cancer, sleep problems, especially like sleep apnea? And then the psychiatric conditions, depression, anxiety, all of those. A family history, finding out if the patient's parents or siblings have had the condition. A social history, especially alcohol abuse or illicit drugs. Current medications, how many times have we heard about side effects and what they can do to the body? The onset of descriptions about the cognitive symptoms, and that's going to be more about when Jeanette would start to see problems with John. Was it last month? Was it 3 years ago? That's going to be really important. Asking about the memory, attention, those things. Behavioral problems, any mood changes or apathy. What are they seeing? Odd behaviors, spending excessive amounts of money, paranoia. So again, John didn't believe that he didn't think it was that bad, but he definitely had poor insight. So activities of daily living, those are the things like bathing, toileting, dressing, the instrumental activities of daily living. This is where we commonly see these things happening first, like John getting lost, the transportation, dings in the truck, the shopping, the budgeting, preparing food. We need to ask about those things too. So the purpose to rule out those reversible causes, and yes, dementia can be reversible. It could be a nutrition deficiency. It could be a kidney disease or electrolyte disturbance. So the providers have to check everything, even heavy metals like mercury. And then of course there's the imaging. So It's important too that they're assessing for a diagnosis other than Alzheimer's disease. It's the imaging that will help detect the brain atrophy that's to support that diagnosis if it is Alzheimer's. The MRI versus the CT, really the MRI, if possible, if they've already had one, CT before, the providers are grateful for that too. But the MRI will actually provide information about the vascular causes of dementia. Okay, so the advanced imaging and tests. Now, this is going to come more from the neurologists and the memory care clinics. After the provider has ruled out the other conditions, it can say, you know what, this is dementia. This is when the high-tech diagnostics begin. This is how the specialists will confirm what is happening in the brain. This is moving beyond just saying this is dementia, trying to find that specific protein causing the problem. The neuropsychiatric testing, again, very in depth, it helps with that diagnosis, and it helps gauge those deficits. The providers seem to refer this or want this to be done when office testing, like the memory test, if it seems to differentiate, like there's a conflict between what was done in the office and what's being presented, or maybe what the caregivers are saying. Maybe when there's a suspected mental health condition where it's, hey, they have depression, but they're showing signs of dementia, this testing would be very helpful. And it's also ordered if there needs to be a definitive diagnosis for the helpful, that's helpful for the patient or the family. And then, of course, we have the scans, these incredible scans. The PET scan, that's a glucose tracer. It looks for the metabolic activity in the brain in different parts. It measures how the brain is using sugar. If parts of the brain are dark, it's not using energy, and not working correctly. So it's high-tech scans like this that help decipher between Alzheimer's disease and say another type of dementia, like frontal temporal or dementia with Lewy bodies. And then there's the volumetric MRI, and I know I have a image right there, and that's going to calculate the volume of the hippocampus to see if it's shrinking. The amyloid and tau scans, these are the gold standard. They're FDA approved, and I know there has to be specific criteria for Medicare to approve. I hear, our providers who are trying to get insurance to pay for these. It takes a special skill set for some of these to, be able to interpret. Or you take like the CSF biomarkers. That's a lumbar puncture. You can't just have anybody be able to draw cerebral spinal fluid, to look for that presence. And then there's the blood-based biomarkers. And, they aren't independently diagnostic yet. They are available at the chain laboratory companies. They are FDA approved, but as of right now, not Medicare insurance covered. But they're measuring amyloid and tau, and there's even home tests, although some providers have some mixed feelings about those home tests. With these, there's cautious excitement. Interpretation of these will continually evolve. It's not yet for the general public yet. And there's that ethical consideration. I think the human consequences of knowing, do I have this before symptoms show? Then what? What if they do? Combined with the clinical and diagnostic workup, this is definitely amazing to have. And we keep hearing what the experts in the field are saying, in neuroscience and medicine. And so the genetic testing involved can identify that specific variant of the gene, which plays a crucial role in the lipid metabolism. Anyway, we start getting into scientific things, but it is a question about genetics and if it's important to the family. So we talked about the assessment and then the advanced testing that leads to a precise diagnosis. And then what? What can actually be done about it, and what's the goal of treatment? important that we manage the expectations. We need to be really forthright with these patients and their families to help them understand that this is a terminal progressive disease. We don't have a cure yet, but let's aim for quality of life. Let's maximize what a person can still do and for as long as possible. So one of the first lines of defense are medications, of course, and there are two classes of medication that are approved to treat the cognitive symptoms. They're there to hopefully preserve cognitive function, and they've been around for a while. So cholinesterase inhibitors, those are most common, and they work by boosting the volume on a key chemical messenger in the brain that's important for memory. So I was listening to a talk by Dr. David Rubin, who's an expert in the field from UCLA, and he was explaining the medication as, the benefit of the medications are kind of are smaller than what we want them to be. But there was reported of a study that said 10% improved cognition, 50% of people that were on the medication felt that they stayed stable. And for Dr. Rubin, it slows the disease by about 6 months. It's typically well tolerated when combined with another one that I'm going to talk about, the memantine, known as Namenda. And this one helps protect brain cells from further damage. So, why not? I think in this situation that if it's going to give you some time and some more functioning, I know that's a subjective decision, but now notice that these medications, it depends on when they can actually be started. And it's not recommended that people stay on them as they're in the severe late phase, but they're for specific types of dementia. Notice that frontotemporal dementia is not listed on here, and that's because it has a different chemical pathway. So the neurotransmitter of acetylcholine isn't affected by it. And so it also doesn't, these medications don't prevent progression from mild cognitive impairment. So it's the side effects are people generally pretty, tolerate them pretty well. The GI upset, the gastrointestinal stuff, that's typically what we hear. So, the efficacy of the drugs, they may be considered modest. The benefit is small, but it's real. It can be benefit. And when talking about a decade-long disease, 6 months may not seem like a lot of time, but for 6 months, that can mean everything to a family. More time to live at home, more time to dress themselves, to do things for themselves. These drugs can delay months, and people can stay at home longer and delay having to live in a long-term care facility. That may buy them time, and time is everything with this disease. Okay, so let's talk about assessing the medication. How do we know if it's working? The follow-up from the provider, they're going to look at what is happening with the person, with their executive functioning, with their, how they're thinking. Are they thinking more clearly? Are they staying stable? That's when we know that it's working for them. Are they more social? And at this point, we really hope that they're able to talk to that. But of course, their caregivers are going to be able to say, I feel like things are better, or they're the same, I haven't seen decline. That's going to be important for them to go over that. All right, let's talk about the cutting edge, the disease modifying treatments that are designed to tackle the underlying pathology of Alzheimer's. So the amyloid immunomodulators. So lecanemab and the donanemab, try saying those fast, right? The lecanemab, it is bi-weekly infusion. And then the donanemab is a monthly infusion. These are disease modifying. The ability to be able to use like your own immune system to clear out the plaques. It's like removing the junk from the brain. I guess that's a way to say it. That's the idea. There is a trade-off, and I'll go over that in a second, but it serves as an antibody, these infusions. with the body's own defense and in trying to remove the amyloid from the brain, leveraging the immune response that we have to remove those plaques, and that have already formed and those that are trying to form. So it's pretty miraculous. It's not a cure. It doesn't reverse the damage that's already done, but it slows the progression, but it has risks. Um, the risks are up to 30% could go through brain swelling. They could have microbleeds, small microbleeds in the brain. Um, it could accelerate cerebral atrophy. It really is a give or take. Um, to some people it's worth the risk, and to some people they just want to be a part of the research, and so it's pretty selfless of them to do that as well. But they're showing, of course, in these clinical trials that 30% um, are able to see a delay in the disease progression. So that's pretty amazing. Um, so they have to be monitored so closely because of these risks, though. And we're talking regular MRIs. And so for people who are considering this, they obviously have to be mild cognitive impairment early in the disease process or really early stage of the dementia. And I put a QR code on here. Our provider, Dr. Michelle Sorwide, she's a specialist in this area, and she is willing to answer any questions that anyone may have about this. There are only a few clinicals in the state and providers that actually offer this and monitor it. All right, so let's go over this, the behavioral symptoms. So sometimes, as we talked about, it's the behavioral changes that are the first telling sign to a family member that something's really wrong with their loved ones. You see the possible treatments and the drugs and the therapies. It's just one small piece to an enormous puzzle. And as the brain changes, so do the behaviors. So treatment just has to be holistic. So with these, up to 90% of people with dementia will exhibit at least one behavior. And what we're talking about here is agitation, anxiety, restlessness, paranoia. Um, it's especially with depression, up to 50% of people with dementia will also have depression. The apathy is a really big one, just losing interest in things that they've always loved. And it's a big one that people don't talk about, the losing the will to do anything. It's exhausting for the caregiver. And this is where the system falls short. Caregiver education, how to manage instead of, reaching for sedating medications. It really is about, can we help people understand how to do it without those medications? And not always. It's not possible always, but we try to teach how to look for, is it pain? Is it hunger? Is it they feel cold and they just can't express themselves? So it's really something we try to go with them to review. And in our clinic, the doctors, of course, are looking at medication. And oftentimes there might be a referral to a Jerry psych provider. We have several in our office who are amazing. And, they specialize in that symptom management of those behaviors. And then, of course, there's the licensed social workers. In fact, my coworker, Liz Garcia Levitt, is on right now. And she sees a lot of, patients' families who are going through this and trying to give them that education and preparation for this, to prepare for it. Okay, so treatment. As we talk about the treatments that are for a disease process that there is no cure, we need to consider palliative care. And I want to say that less than 40% of people with dementia actually go to utilize palliative care. When this is a neurodegenerative disease, it's progressive and ultimately terminal. To prepare for end of life care and advanced directives, to allow them to have that voice, it's better sooner than later. So people with dementia, we've learned that they receive suboptimal care um, towards the end of life. And so, especially overly aggressive treatments, um, poor pain management and symptom management. And so, the overly aggressive care is traumatic for everybody involved. And it makes you wonder that if we provided the right education and got the right care on board, would that decrease and improve quality of life? So people get a little nervous when we start talking about palliative care and hospice care and what's the difference. And again, as we talk about the benefits of both, it's just something that can be started sooner than later. In palliative care, what that does is it takes diseases that are chronic, that are terminal, and they give people almost everything that a hospice does, right? But it's not end of life yet. People still go to the hospital, they still get antibiotics, but they have social workers and chaplains and pharmacists. They have a team of people to help with symptom management at any stage of the disease. People can get started on palliative care. And then, of course, transitioning to hospice at end of life. When there's no more curative treatment, that's just, it's just really important that we can give symptom management, not just for the patient, but also for the caregiver and family members. So let's talk about a summary of John, who transitioned through the different processes as we talked about. Memory issues cannot be dismissed as normal. What if they are what if reversible, excuse me, and what if they're not? Then there's time to plan. But it begins with that comprehensive assessment by a medical professional. Um, a confirmed diagnosis is absolutely critical. There are medications that can potentially help. There are treatments that are continually being developed. There are the non-pharmacological treatments, the therapies, the social workers, everybody involved in this. Importantly, there's ongoing support and education, collaboration with providers, involving palliative care and hospice care when appropriate. Receiving an Alzheimer's diagnosis must be frightening. Maybe it's not surprising. Maybe it's a relief that people finally have an answer to explain all the changes in their loved one. But then what? People have said that they've been told, okay, you have a diagnosis, good luck, come see me in 6 months. Or I remember reading something about a provider kind of saying, okay, it's Alzheimer's, so get your affairs in order. And I don't believe that happens all the time, but when it does, people are left and get lost in the shuffle. So this is why advanced care planning is so critical. These conversations have to take place while the person is still able to make their own decisions and talk about, decide on their healthcare proxies. They can't wait too long from diagnosis. They have to receive that education. Support isn't just nice to have, it's a core part of the treatment itself. This is the gap right here. This is the crisis for families. When they have the diagnosis, there's confusing treatments to them, behavioral changes. This is where we should step in. And so CMS, Medicare, they did. Introducing Guide is designed specifically to provide comprehensive coordinated care. It's centered on the patient and the family. This is the first time in the history that a program of this scale is acknowledging a shared family experience with dementia. It's an 8-year pilot program, and what sets it apart is that it acknowledges that we have to involve the family in order to provide that quality care. It's accessible, it's free, there are no copays, people get to keep their same doctors. Guide adds an additional layer of support on top of the patient's current team. And these are the different things that have to be that are required for a part of Guide, and I'll go over those in just a second. So those with cognitive impairment and mild cognitive impairment diagnoses, they don't qualify. the person has to have a dementia diagnosis. Yeah, and this is again a program for people navigating this journey at home. Um, they have to have Medicare Parts A and B. Sadly, Medicare Advantage does not qualify people for the program. They can't be on hospice, and they can't be living in a long-term care facility. Assisted living is okay though; they can be living there or in a memory care. Again, that caregiver support, we're looking for them as well. So what we do is, we talked about the comprehensive assessment. It's ongoing support, nonstop support. It's 24/7 access to a care team. It's care coordination. If they go into the hospital, we're following right along with them in terms of making sure that all their healthcare team is collaborating and staying in touch. The thing that really jumps out about this program is the respite care option. The program provides the direct financial benefit for respite services. It's up to about 25, almost $2,600. So the caregiver can have a break. It's the single most important intervention to keep the person with dementia at home longer, and keeping the family unit from possibly collapsing in a sense under that caregiver burden. So this gives you just kind of an idea of what guide could look like for different people involved in the program who would be. Of course, I made up the names here, but you have somebody like Fred and Wilma. Wilma has dementia, but Fred is also really struggling with his health. He's having hospitalizations and increased clinic visits. What is he going to do? Who is there to help him? So our social worker may arrange a family meeting, finding out who is your support system. We're going to get respite care in there. Personal time for a caregiver to come in, a paid caregiver, paid for by Medicare. And so Fred could have some time to rest or go to his appointments. May have to look at assisted living options or a memory care for Wilma. You have other couples. We have people who live alone, diagnosed with dementia, and family lives far away. They want reassurance. They need education on how to prepare. So as you can see, we have different kinds of patients that can qualify for the program, and there's something for everybody. Something that Liz and I have been participating in our clinic is a support group. And there's not enough support out there for these people. And to hear the spouses, the daughters, the sons, the loved ones, the friends who are helping care for their person with dementia, they have a lot of questions. And I'm grateful that we can take that information and let our providers know as well about the needs. All right, so how to enroll in the program. Like I was saying, eligibility, you have to have that Medicare A and B. And the CMS website will show you we are one of several in the state of Utah. But like we're doing it, Intermountain Healthcare is a part of Guide. You have AMG, who are in-home care providers, and they're doing Guide. So we have programs that are local. There's some national ones that are trying to reach out to the southern part of the state and the more rural areas. So once you determine which program to go with, you call to make an appointment, and you let them know interested in the Guide program. There has to be a comprehensive cognitive exam assessment, like we talked about, to rule out anything, just to make sure that dementia diagnosis is for sure, or to get one. And then CMS will approve it. So Medicare will say, yes, this person qualifies. And then Guide services are started. And those who qualify for the respite, then they will be able to get that going as well. And there's also a home safety assessment. That's one of the requirements that we do to go to the home, provide education, look for any concerns we might have. Are there scattered rugs on the floor? Should they put up little signs to remind so-and-so that this is the bathroom, or, should the basement steps be blocked off because of a risk for falls? So we're going in there into the homes and we're looking for that. And I think that's one of my favorite parts of this program is being able to have that one-on-one time with the patient and their family and being in their environment is really fulfilling, and to be able to see pictures and get to know them. So I'm grateful for that time, and making sure they have grab bars. I should say that grab bars in the bathroom. What do we see that will hopefully allow them to stay at home longer and safer? That's a goal, and that's quality of life. That's where people want to be. All right, so let's talk about the key takeaways of the guide program. So guide aims to complement the existing services provided by Medicare. Um, it hopes to fulfill the needs of the patients and their families, especially when we think about dementia care. People have their pulmonologists and their podiatrists and their dermatologists, but what about their cognitive care? And so it's not intended to replace any current services, but rather it's enhanced care. It's holistic, person-centered care. Um, so, to know that it's free, I can't express that enough. And I think it's been a real relief for some of our patients. No copays. They don't have to change their benefits. They can stay with their doctors they're already using. So, it doesn't restrict their ability to receive other health services. Again, they have to have that dementia diagnosis either confirmed through a guide provider, guide clinic. It's not Advantage plans. They have to be traditional Medicare. I'm trying to think of what else here. Okay, eligible patients, again, require that assessment, and then they require approval from Medicare to be a part of it. And, there are growing pains. It's a brand new program and it's being worked out. But the core part, the heart of it's there. It was put together and developed by the best dementia programs in the nation: UCSF, UCLA, Indiana, Rush, just all these incredible programs around the nation. And now they want to standardize this care. And that is why this program was even brought up. So it's come a long way, and it has a long way to go, but we have the foundation, and that's important. I feel like it brings us back to this powerful idea by Scott Kirsenbaum, and it grounds this whole discussion. Though those with Alzheimer's might forget us, we as a society must remember them. And that's the challenge for all of us. We think of how we can advocate for this vulnerable population, we need to support them in our communities. What role do we play? The plaques in the brain are a biological problem, but the gaps in the care, that's a social problem that we can work on solving. And starting like the guide program, that's a huge leap. And so we're here for it. So, all right. Thank you. Thank you for this time and opportunity. And we'll take any questions you may have.